of those treated with cisplatin and vinorabine. And again, as predicted, they had less gastrointestinal and hematological toxicities. Serious adverse events, those that lead to admissions, much more significant impacted quality of life, 7% with gefitinib and 23% with chemotherapy. And in quality of life questionnaire, again, gefitinib better than chemotherapy. So this is efficacy. This is disease-free survival. And as you can see on the blue curve, that's the chemotherapy, and the red curve is patients treated with gefitinib. So gefitinib seemed to do better in patients with an EGFR mutation versus cisplatin-based chemotherapy. So that's the new standard of care. No, it is not. And why not? Because one of the obvious issues of this trial is, what about chemotherapy followed by gefitinib? Just like in the trial that I showed you before. Should one really not give chemotherapy at all to these patients? I actually don't feel strongly about that aspect of the question. I feel much more strongly about, I don't know if this translates to my practice, because everybody does terribly. So remember, these are patients with stage 2 and 3A treated with a curative intent. Though this is a Kaplan-Meier curve, it looks like nobody's cured. And a cure rate that includes patients with stage 2 and 3A of 0 is certainly puzzling, to say the least. So I'm not sure how to translate these results into my practice. If you're really skeptical, you can do this and cut the 24 months of the administration of gefitinib, and then the separations of curve for disease-free survival are much less significant. So once you stop the medication, then they tend to converge even more together. But this issue is being studied on a national trial called the Alchemist trial, and it may or may not be open around here. Patients that have an EGFR mutation are randomized to receive erlotinib, and I don't think that there is placebo anymore. They stopped that nonsense. And those that have an ALK mutation are randomized to receive crizotinib or nothing. And now there is an added arm, which I added there, for patients with squamous cell carcinoma or those that don't have mutations. They can be randomized to nivolumab or observation. Okay, so that's what's cooking in terms of adjuvant therapy for non-small cell lung cancer. Let's talk about the therapy of locally advanced disease, which the standard of care has changed dramatically over the last year. So this is the Pacific trial. It's a 2-to-1 randomization of durvalumab or placebo every 2 weeks for 12 months, to be started from days 1 to 42 after the completion of chemoradiation therapy. Those are patients with stage 3 that had no progression of at least 2 cycles of platinum-based chemoradiation therapy. There was no PD-L1 requirement, and the number of patients that were calculated for this study was based on a hazard ratio of progression-free survival of 0.73. 709 patients were treated against a 2-to-1 randomization, and carboplatin was used in 42% of patients. And the most common regimen was carboplatin and paclitaxel, followed by the second most common being cisplatin and etoposide. So these are the patient characteristics. Just want to point out a few issues. One is that there is an almost identical distribution between stage 3A and 3B in this trial, as it's actually not uncommon in trials of patients with stage 3 to chemoradiation therapy, and it almost equally divided between squamous and non-squamous as well. So toxicity, as it turns out, there was some justified concern regarding adding immunotherapy after the completion of radiation to the lung. Will that then lead to higher rates of pneumonitis? And as it turns out, that turned out not to be the case. It seemed actually quite well tolerated from that standpoint. So if you look at pneumonia, quote unquote, grade 3 and 4, it was 3.8% in the placebo group and 4.4% in the durvalumab group. Pneumonitis leading to discontinuation, 6.3 versus 4.3. Death due to adverse events, no difference between arms, but in any case, numerically even worse in the placebo arm. Use of high dose of steroids, 5.1% in placebo and 8.8 with durvalumab. In grade 3 and 4 immune events, 3.4 in durvalumab and 2.6 with placebo. This 3.4 number for durvalumab seems low, and I don't have a good explanation for that. Usually I quote my patients a 5 to 10% risk of a severe autoimmune reaction. So, as you may remember, this was calculated, the number of patients needed was calculated based on a hazard ratio of 0.73, and what they got was a hazard ratio of 0.52. So it ended up being much better than they even predicted it would be. And I don't treat lymphoma, but based on my days way back then, it looks like a lymphoma type of therapy in terms of the separation and efficacy of therapy. So much has been said about the issue of the 2 weeks of starting treatment. And that is actually on the paper buried somewhere in the appendix. And it's this issue of the different hazard ratios if you start within 2 weeks of the completion of radiation or not within 2 weeks of the completion of radiation. You know, I've never been accused of being wishy-washy about my opinions, and I think this is nonsense. You know, there has been a lot of talk about it. There are so many confounders here. You know, obviously, if someone is having more hard time recovering from their chemoradiation, they will be started later. Is that what really determines who's going to be doing better or worse, or it could be just some statistical flaw? I find hard to believe that a 1 week difference in the starting of durvalumab would have any impact. But you've seen it because you're going to hear about these 14-day thing and whatever. So there is a lot of also criticism about the fact that this FDA approval was based on progression-free survival and not overall survival. So this is also from the appendix, and it's the time to death or development of distant metastatic disease. It's not an overall survival curve. Events here are dying or developing metastatic disease, which ultimately should lead to death. And as you can see, there is a pretty dramatic separation as well in favor of the durvalumab curve. So I think that as matures, it's hard to imagine that we will not see a survival difference. So one issue is this for everybody or not? And what about patients that have an EGFR mutation? What should we do with these patients? There is obviously a lot of data showing that patients that have a driver mutation have lower response rates to immunotherapy. In fact, with the EGFR, that seems to be a little less the case in comparison with ALK, where having a response to immunotherapy is almost reportable. It's incredibly rare to see an ALK-mutated patient respond to at least immunotherapy we have to offer today. So if you look at the EGFR positive patients, the dot is the correct side of the forest plot. meaning there is a survival, there is a progression-free survival improvement. The hazard ratio is 0.76, so it's not as good as the overall population in the study. And does cross 1, obviously we're talking about a very small number of patients, so that's not surprising. Before you start denying this therapy for patients with an EGFR mutation, I want to point out another group, and that's the non-smokers. Obviously we have no data regarding what kind of molecular profiling these patients had, but I would postulate that they have a higher chance of having a driver mutation, and hence should be less responsive to immunotherapy. But here you're seeing a hazard ratio of 0.29, which seems to be better than the overall population study. So I'd be very careful about denying this therapy to anyone based on their molecular profiling, at least as of now. So there are some issues to be considered. There is no chemotherapy allowed in this study. That means that the patients treated with, and Jack was in our discussion of how we would incorporate these into our guidelines at the SCCA as a special guest, which is always a pleasure. And we had a lot of discussion about this, because according to the design of this study, it would be perfectly acceptable to give as the only systemic therapy that is not immunotherapy to these patients 6 to 7 doses of weekly